short video presentation will briefly review the use of the mannequin and doll for the management of shoulder dystocia. In particular, we want to demonstrate the internal rotatory manoeuvres which seem to cause much confusion in workstations. Remember that in teaching this workstation, we're trying to demonstrate that shoulder dystocia is a bony impaction of the anterior shoulder against the back of the symphysis pubis. During the workstation, it's important to try and mimic shoulder dystocia by raising the doll so that the anterior shoulder truly impacts against the back of the symphysis. This will give the student the impression, at least, that there is a bony disproportion. The first manoeuvre results in an increase in available pelvic diameters. This is nicely demonstrated using the McRoberts manoeuvre to hyperflex the hips. Notice that during hyperflexion the sacral promontory moves backwards, thereby increasing the available pelvic diameters. Great care should be taken when demonstrating this manoeuvre, as it can lead to damage to the pelvic mannequin. We would suggest that this is only demonstrated once. Other manoeuvres will lead to narrowing of the bisacromial diameter and adduction of the shoulders in front of the baby. Manoeuvres such as suprapubic pressure from behind the baby lead to this successful narrowing. The third method that you can demonstrate is shown here, where suprapubic pressure from behind the baby's shoulder leads to rotation of the shoulders into the oblique diameter. Hopefully in that position the shoulders will slip out from under the symphysis and the baby can be delivered. We can now demonstrate this with the doll in the pelvis. Suprapubic pressure resulting in rotation of the shoulders into the oblique and successful delivery of the baby. We're going to finish by demonstrating the most difficult manoeuvres. These are the internal rotatory manoeuvres and have often led to confusion during the workstations. This video is supported by a leaflet available on the website. It's important that you encourage your candidate to enter the pelvis by inserting the fingers at either 5 o'clock or 7 o'clock. In this case, in an LOT position, the fingers are inserted through the introitus at 5 o'clock. There, the fingers are angled sharply upwards so that the fingertips lie on the posterior aspect of the anterior shoulder. Pressure is applied with the fingertips to the posterior aspect of the anterior shoulder, trying to rotate the shoulders into an oblique diameter. If this is successful, the fingers should be removed and an attempt made to deliver the baby. In this case, pressure on the posterior aspect of the anterior shoulder has been unsuccessful and the baby has not rotated into the oblique diameter. In this LOT position, keep the fingers of the right hand where they were already placed. If possible, insert 2 fingers of the left hand at 7 o'clock to lie against the anterior aspect of the posterior shoulder. This is adding wood screw manoeuvre to the Rubin 2 manoeuvre and hopefully achieving rotation in the same direction. If rotation into the oblique occurs, both hands should be removed and an attempt made to deliver the baby. If delivery is unsuccessful, reinsert the fingers of both hands and continue the rotation through 180 degrees. During the manoeuvre, you will likely have to remove your hands and replace them in a slightly different position to complete the 180 degree rotation. Screw manoeuvre frees the shoulder from under the symphysis pubis, and rotation allows the baby to screw down with the anterior shoulder delivering. If there is no rotation whatsoever with the addition of wood screw manoeuvre, firstly remove the fingers of the left hand, then slide the fingertips of your right hand down to lie against the posterior aspect of the posterior shoulder. Finally, by exerting pressure on the posterior shoulder, you may achieve rotation of these shoulders into the oblique. In that position, it is worth an attempt at delivery. Should that attempt be unsuccessful, reinsert the fingers of the right hand and continue rotation through 180 degrees. This is the reverse wood screw and may result in successful delivery of the baby. To successfully undertake the internal manoeuvres we have just described, it is likely that a generous episiotomy will need to be made, and notice the positioning of the mother's buttocks at the edge or end of the bed. By encouraging your candidate to kneel in front of the patient, it makes it much easier to insert the fingers from behind and below the fetal head. Here are the hands successfully inserted for combining wood screw manoeuvre with the left hand and Rubin 2 manoeuvre with the right hand. In this case, you will see that there is difficulty in inserting the fingers because of a tight introitus. In this case, abandon wood screw manoeuvre and move straight on to a reverse wood screw manoeuvre, rotating the baby in the opposite direction. To thank my colleagues Dr. Padma Manjuluri, John Short and our little friend in the middle for helping us make this video, I accept full responsibility for this completely amateur effort.